Hello, and thank you for inviting me to speak to this workshop on this topic. These are my declarations. So I'm going to speak initially about what we currently know about sleep disturbance amongst HIV patients, and I include in that criteria insomnia, poor sleep quality and sleep deprivation. But I'm mainly going to focus then on the findings from a recent intervention study in our centre, just to highlight what can be done to help patients who are struggling with sleep problems in a clinical setting. And because there are no record guidelines on this area, just to conclude with one or two recommendations. So what do we currently know about the prevalence of sleep disturbance amongst HIV patients? Well, most of the studies will show the rates are much higher in HIV compared to the general population, depending on which population is sampled, anywhere between 30 to 100% versus 30% in the general population. There are a number of HIV negative match control studies which show rates of insomnia up to as much as 5 times higher in HIV patients compared to negative match controls in the over 50s. In terms of causation, the main risk factors focus on depression, anxiety, recreational drugs, and duration of HIV and on antiretroviral therapy, all strongly associated with the development of increased sleep problems. What about the role of antiretroviral therapy? Well, we know with efavirenz via its neuropsychiatric adverse effect as high as 35%, that sleep disturbance and insomnia are a very significant component of that adverse effect. But there is also some emerging evidence and some reports showing that the integrase strand inhibitors may also be associated with increased risk of sleep disturbance. In particular, dolutegravir leading to higher discontinuation rates due to adverse effects compared with other integrase strand inhibitors. But then there are other studies that show there's less difference between the individual integrases, with a rate of sleep disturbance and insomnia between 3 to 8%. Likewise, there's been a number of patient-reported outcome ARV switch studies that have shown that improvements in sleep disturbance from switching away from dolutegravir-based regimes to a bictegravir TAF-FTC, and also from efavirenz to bictegravir TAF-FTC, both showing improvements in sleep disturbance and sleep quality. But there are no studies to date looking at switching ARVs and the impact on sleep disturbance. Now, in these studies, and indeed our own study, the main risk assessment tool that's used to assess sleep is the Pittsburgh Sleep Quality Index, or the PSQI. It consists of 9 questions covering 7 sleep domains. It's simple and easy for the patient to fill in. They can do it in clinic. And each of these 7 sleep domains, when it comes to scoring, accrues up to 3 points. So you can get a total composite score of 21 points, and a score of greater than 5 is deemed indicative of a significant sleep disturbance. And the higher the PSQI, the greater the severity of sleep disturbance. And in this study, we just compared the overall mean global PSQI score of one group with another. In terms of recruitment for the study, so we initially assessed patients attending through our routine clinics over a 3-month period, and we screened them initially with some sleep screening questions, just a few discriminatory questions, in order to identify if they currently had some kind of a sleep problem. And out of those 150 patients sampled, 40 of them, that's just under a quarter, were identified as having a sleep disturbance. Those 40 were then subjected to further assessment using the PSQI, and out of those 40, 37 of them, that's just over 92%, scored 6 or more on the PSQI. And those 37 patients, they formed the study cohort for intervention, and they were all given 2 interventions. Firstly, they were all given sleep information in the form of standard sleep hygiene leaflets. In addition, we assessed their current antiretroviral therapy with a view to switching if we thought it would help their sleep disturbance or cause less aggravation and was clinically indicated. And then we repeated the assessment again at least 2 months later to see if any impact had taken place. I'll just walk you through the baseline characteristics of the study cohort. So the first thing to point out is that the overall mean PSQI was 12, indicating a moderately severe sleep disturbance. It also reflects the fairly stringent criteria for recruitment that we applied. You'll see that 60% had reported a current or previous mental health problem, 92% had undetectable viral load, and the mean CD4 count was 971. In terms of duration of ARVs, just under 10 years was the mean on ARVs, and in terms of the third agent, which is what we're interested in, over 2/3 were on an INSTI-based regime at baseline, and just over a third of patients had indulged in recent substance misuse, and a third of patients had reported a recent acquisition of STI in the previous 6 months. Just to remind you again of the intervention itself, this shows you the distribution of the intervention. So the 37 patients all given sleep hygiene leaflets, 20 of them had leaflets only, that's 54%, and 17 patients consented to switch in addition to the leaflet, that's 46%, and all but 2 of those 17 patients that were switched to bictegravir TAF FTC. And the reason behind that is that the sleep disturbance was the main driver for switch, but we had to consider potential toxicities, DDIs, pill burden, dosing schedules, etc. And so Biktarvy was deemed to be the most suitable agent at the time for them to switch to. And just to show you what the third agents these 17 patients were taking prior to switch at baseline, 59% were on dolutegravir, 23% raltegravir, and 18% on efavirenz. So I'm now going to show you the results of the intervention itself. So the blue bars represents the overall mean global PSQI, and the brown before the intervention, and the brown bars after the intervention. And you can see the first set of bars show there was a reduction of 36% in the overall mean PSQI score. That represents an improvement of 36% in sleep disturbance. The middle bars are the patients who were given leaflets only, and that shows a more modest reduction, improvement in sleep disturbance of 20%, didn't quite reach statistical significance. And the third set of bars are the subgroup that had their ARV switch, showing you a more striking improvement of 54%, and you can see that we've rendered them from a moderately severe PSQI score of 12.18 to a near normal score of 5.59. And then we just repeated the analysis again, just adjusting this time for those 60% who reported mental health problems, and you can see almost identical results. So 36%, 37% overall improvement, 22% leaflets only, and 53% ARV switch, which just illustrates that patients with mental health problems responded equally as well to these interventions as those that didn't report mental health problems. So although this is a very small study, small numbers, and it's not factored to account for confounding variables, we do think we can conclude that the idea of assessing patients initially with a few questions, simple sleep quality questions, and then assessing in more detail using the PSQI, identified the majority of patients with significant sleep disturbance. And yes, we know that mental health is highly represented within HIV cohorts, as it was in ours, but the main thing is that it did respond to the measures that we implemented, which is reassuring. And although the majority of patients, the most significant improvement was with the ARV switch, nevertheless we like to think of it as a package of care, and the sleep hygiene information is also important for improving sleep quality. And not all patients will respond to these measures, and in those particular cases referral to psychology or mental health services would be appropriate. And in the patients that responded had the profound improvement on ARV switch, we don't know whether this is a purely pharmacological effect of the agent or whether it's an individual susceptibility to that particular drug, but from the patient's point of view, they are very, very grateful. It's improving their quality of life, and the feedback we got back was very positive. And finally, just to say that this whole area does fit in with the 4th 90th, and we'd encourage clinicians to routinely inquire about sleep quality amongst their HIV patients attending clinic, and if they're on an ARV regime that may be exacerbating or aggravating sleep disturbance and it's clinically indicated, then to consider be a bit more proactive in switching to an alternative agent. Thank you.